In Italy, you know, we have Azzaro, that is the same as Dysport, and Vistabel, that is the same. The vial, 125 units, Dysport. I use one vial, 125 units, 125 units, and I get perfect results. But I am very careful to inject superficial and with the good dilution. Never I get a non-responder patient. Sometimes maybe a few parts laterally here that I have to re-inject through the, but quite never.
So you don't recommend that we increase the dose? Or?
No, no. If you increase the dose, this is my opinion, of course, something wrong in the technique. You go too deep. You don't get the target. The target is so.
Here's some examples of venous disease. This patient over here has varicose veins in the back of the knee. This patient has your lipodermatosclerosis. This is your inverted wine bottle that they call. And this over here is your ulceration. So this is your end stage of venous disease. So there's many treatments out there that can be used. I'm going to fast forward the talk a little bit more to go to the sclerotherapy part because of the interest of time. And sclerotherapy has been used to treat veins for many, many years. Here are the key principles when treating a patient with sclerotherapy. You want to treat the largest vein and then the smallest vein. You want to treat the entire vein all at once. Compression is needed during and after the treatment, and the patient should be able to walk after the treatment to prevent any blood clots. So once again, reflux. In an abnormal vein,
some of those repetitive slides, but I'll focus on sclerotherapy of the hand, which is definitely different than the legs. These are my disclosures. I've done work with MERS. They make a sclera. It's really the only real disclosure for the sclerotherapy part. For the filler part, I primarily use calcium hydroxyapatite for the back of the hands, but you can use other fillers, HAs, and they work well, and I've done work with those companies before. So the back of the hand, this is what someone in their maybe 50s will look like in terms of the back of their hand. They're going to have some volume loss. The tendons and veins become more prominent over time. They develop sun damage. Now, if they're lighter skin, they're more likely to have sun damage than if they're very dark skinned. Obviously, the more melanin we have, the more sun protection we have innately. And then in everybody, especially lighter skinned patients, the back of the hand, the skin becomes thin, powdered lidocaine, which doesn't mess with the G' of the substance. But if you don't have that built-in lidocaine, you could just add a little bit of fluid. And realistically, even if I am using Radius Plus, I will still mix some saline into it. I want a little bit more waterier product. The thicker the product, the more likely you're going to get some lump or bump in the back of the hands. I inject superficially into the superficial areolar plane, the superficial lamina. You want to see the hub, the tip of that cannula almost kind of peering through the skin. If you lose sight of your cannula, you're too deep and you're more likely to get adverse events. And I inject between the 2nd and 5th metacarpophalangeals. So I'm injecting here. I don't inject into the snuff box. I don't want to go too laterally on the hand either. And I'm doing small boluses, tiny little injections like peas in a pod as I withdraw. Injections like on the face or other parts of the body, you don't want to see that needle or cannula view, but here you do. So again, I'm just doing little forward movements. I'm not ramming the cannula. I'm trying to be as gentle as possible. And the more tightness you have, the more you have someone stretch the skin out for you, and the more they flex their wrist like this, the easier it's going to be to inject the cannula. So I've actually changed my injection technique, and I hopefully next year, if I'm invited back, which I really appreciate being here, I'll show you my updated technique. But I always have them flex their wrist, because the tighter you can get the hand, the less trauma you're going to need to get into that layer and move your cannula through the skin. And that works on any part of the body. And I find it to be very much more pleasant for the patient and less painful. Because what hurts with a cannula is when it gets trapped in something, when it gets caught on some kind of collagenous or fascial connection. And so
be in the dorsum of the hand.
Then in the legs?
Yeah, I guess in the legs it's safer. Exactly. I think it's not allowed to inject sclera when the vein is larger than 3 mm. Correct me if I'm wrong.
Yeah, and it's a great question.
Thank you.
And the answer is I'm not sure if there's a higher risk, if it's the same risk, or if I think they're both low risk. Now, when you say an embolism, you could mean you create a clot that then moves out of the area, or is there a greater risk of the product moving farther up into the extremity, potentially acting on areas where you don't want it to act?
Yeah.
And that may be true in the hand because you're using the hand constantly, right? So you're putting it through some contractive effects. But realistically, you're not putting a lot.
And moves in the same time with the depressor septinasi. Very particular wrinkles, and it is the only one indication when I inject the nasal spine with botulinum toxin. Otherwise, for gummy smile, I inject the alanasi and the levator labii alequenasi. In this case, you see that she moves a little bit all the muscles. Now, the lip has a shape downward, concave, and all the muscles that you move, levator labii alequenasi, levator labii superioris, zygomaticus minor, and major. And this is why the patient came in my office, in my clinic, because she hated this particular movement down due to the very important to inject also bunny lines to balance the result on glabella. Remember, when you have these cases, you must inject also bunny lines. And this is the characteristics of the patients, especially below. The suggestion of the company is to inject on label units. So in this case would be 50 units Dysport for glabella and 30 units per side Dysport for CrossFit. Using Botox or Xeomin would be 4 units in each point for on label. But I was afraid, and so this is what I really injected. And so you see around 20-25 units. The mouth, in all these little parts, you will get a perfect result. Natural, this lady never will have a perfect face, but you must connect different techniques. As for sure, you can agree with me. And these wrinkles, with a light reduction of the movement, we put maybe also the vasting. I think to possible ischemical complications that can happen with the use of these. First of all, as always, it's important to understand the anatomy in the face and which are the main danger areas anatomically for the problems. The temples, the lateral part of the skull. The temples are a particular area. Here we can do for the hollowing of the temples many injections that can be done to improve this hollowing, especially in these ears where we inject sometimes the zygomatic bone, and so increasing this infraorbital nerve and infratrochlear nerve, zygomatico-temporal and zygomatico-facial. All these nerves have an artery and a vein. So when we enter with the needle within, nearby the eyebrows or here the infraorbital foramen, it is dangerous. So we have to think that if we inject, we can also close these are very little vessels. We are speaking about 1 millimeter around, no more. Then laterally to the eyebrow, here we have the lacrimal gland. And all we know how much important are the glands and how much sensitive are the glands to botulinum toxin. So if we